Hi, good morning, and welcome to Grand Rounds on this brisk winter day. We're really delighted to have Dr. Eimear Kenny and Dr. Noura Abul-Husn with us today. Dr. Kenny is the founding director of the Center for Population Genomic Health and Associate Professor of Genetics and Genomic Sciences at the Icahn School of Medicine at Mount Sinai. She received her Bachelor of Arts in Biochemistry from Trinity College in Dublin, and then her PhD in Computational Genomics from Rockefeller University, and then completed postdoctoral work at Stanford University. Dr. Abul-Husn is the founding clinical director of the same center at the Icahn School and is an associate professor both in medicine as well as in genetics and genomic sciences at the Icahn School of Medicine at Mount Sinai. She received her Bachelor of Science in Life Sciences and her Master's in Pharmacology from Queen's University in Canada, followed by her MD and her PhD from the Icahn School, and then did a combined training in internal medicine and genetics, also at the Icahn School, followed by a chief residency in genetics at the Icahn School. All of us involved in clinical care in the course of a year, sometimes a month, sometimes a week, even a day, will have the experience, first, of taking care of patients where really we don't have any good therapeutics to provide to them. In my own instance, my Hermansky-Pudlak patients who have HPS, pulmonary fibrosis, there's really no good treatment for that fatal disease. Or we have experiences with patients because of their personal histories, what we know about their families, their gender, perhaps their size, something having to do with how they responded to other agents in the same class. We'll have the feeling of throwing drugs at them, but a little bit of trying to force a square peg into a round hole. That we have a sense that this medication we're going to provide to them is maybe the best we have to offer, but it's unlikely to really get them where we're hoping they would get in the course of their illness. And of course, in the world of prevention, we're always trying to catch up. We're trying to always understand better who's at risk for what and why, and when we really truly should be intervening in their care. And sticking with my own example, in pulmonary fibrosis, we really don't know when we first should start screening for pulmonary fibrosis in the Hermansky-Pudlak population. And into that broad void step people like Dr. Kenny and Dr. Abul-Husn, who through creativity and expertise are really helping us understand and move forward dramatically in the care of those patients across the whole spectrum, from prevention to diagnostics to therapeutics. And we're really delighted to know that people like you are out there doing the good work to help us all take better care of our patients and help us understand in the broadest terms possible how to improve their lives. Welcome.
Good morning, and thank you so much for that introduction. That's really wonderful, and we hope we can live up to it. So this morning the talk is a little bit different. You're getting a 2-for-1, and I'm going to go first. As mentioned, my name is Eimear Kenny, and I'm the director of the new Center for Genomic Health, which is sort of softly launched now. We'll have a formal announcement in the new year. Before I start, just some disclosures for myself and Noura. Okay, so as Dr. Stewart mentioned, much of what we're going to talk about today has come about because of a abundance of a new technology. The technology is over a decade old now, but really is one of the fastest growing technologies we've known as humans. Resulting in a precipitous drop in the price of sequencing genomes. You as a private citizen today could take your credit card and go to a website and have your own genome sequenced for less than $1,000. In the research setting, it gets even cheaper, and we have all sorts of technologies where we can cheat a little bit and really drop it down to tens of dollars. Such that today in the world, there's an estimate of nearly 100,000 humans sequenced, and pretty soon in the next couple of years, you can imagine that that number is just going to rise very, very quickly. So in this era of having a lot of empirical data about the genomes of us as a species, we can really start to think about how this changes the way we think about all sorts of aspects of society, industry, and healthcare. And what we're going to talk about today is a way of thinking about healthcare in a genome-first paradigm. So this is not a new idea. Many people have been thinking about this for quite some time, but waiting for the day in which this could become a reality. Indeed, here in the US, in about 2015, President Obama at the time launched what was known at the time as the Precision Medicine Initiative. Today, it's called the All of Us Research Program that aims to sequence the genomes of over 1 million Americans and follow people throughout their life course to understand how that information can impact their health outcomes and disease. So how will genomics change the way in which we practice medicine? Well, some of this is already occurring today. So we're already using genomics for diagnostics and for family planning, let's say. But there are other ways in which genomics will change. It's quite easy to predict will change health. We can already know that there's a lot of people who access genomics outside of health systems through direct-to-consumer companies. There's about 20 million Americans who have their genomes in direct-to-consumer companies. We can think about applications such as pharmacogenomics. And one application that we want to really focus on today is this idea of using genomes to screen for early detection of disease in a paradigm for preventative health. We are not the first and we're not the only people thinking about this. As I mentioned, we have a big national program in the US called the All of Us Research Program. There are several programs being launched at the level of individual health centers, at the level of states, at national levels. So there's a program out of Geisinger Health System in rural Pennsylvania. They were, frankly, one of the first health systems to think about this in a large capacity. But really, you have programs being launched almost every week. There was an announcement only a couple of weeks ago that 5 million people from the UK would have their genomes sequenced. Programs out of China, out of Finland, and several different health systems across the US. So as we are launching programs like this, we really have to tackle not only the opportunities that we can get excited about, but also the challenges that we are going to encounter. Here's one of them. Here is an article that came out just last month from the UK that highlights that the engines that are driving a lot of our discovery capacity that we could translate into clinical care are rather biased for some a small slice of humans, a small slice of human diversity. This is an article that was drawing attention to this. On the left side, there's an article that me and others wrote a couple of years ago that drew attention to this. And, we may not be able to change this bias in terms of sampling of genomes in the engines that we're using, but we ought to account for it. We ought to start to include and mindfully include more diversity and account for the fact that we have certain populations represented and certain populations underrepresented. How are we going to handle that for providing evidence for the types of new medicine approaches we want to apply? So in late 2018, what are the key questions driving this idea of genomic medicine? Well, in our opinion, here are some of them. How will increasing depth and diversity in genomics, and particularly for a health system in New York City, this is a very important question, in genomic clinical engines, increase genomic discovery and translation potential? Once we've identified genes that are clinically relevant, how do we identify populations at risk, and how do we actually impact health outcomes? And this is the idea of a genome-first model of medicine. And this is not by any means a trivial problem, because I don't know that anybody has this solved yet. How do we integrate genomics broadly in health systems for improving healthcare management? Since we're in the Mount Sinai health system, we can think of this impacting patients from the 5 boroughs of New York City. So here is a heat map that actually shows where our patients come from. So this is taking data from our health system now that it's almost entirely nicely integrated. We can do these kinds of exercises and showing of the 70 or so neighborhoods around the 5 boroughs of New York, where do our patients actually come from? So as you can see, most patients come from pretty close proximity to the main hospital campus, but there's a lot of patients also coming in around Sinai West here. But really almost every neighborhood is colored in purple here, showing that we have an outreach, at least in the 5 boroughs, to almost every neighborhood around New York City. So if we're thinking about questions of diversity, here's one way to think about that. And in this exercise, we take that same map, but now we just color it using data from the US Census categories, thinking about race and ethnicity. And here each neighborhood is just colored in a color based on a majority race ethnic group in that neighborhood, or purple if there's no majority. So that we see that New York, unsurprisingly to us, is a very, very diverse place. With a very colored map of the types of diversity encountered. If I were to take that and just plot it in a pie chart as here, you could see that that looks something like this. About 33% of New Yorkers are white, about 26% are African American or Black, 28% also self-identify as Hispanic Latino, about 12% Asian, and 4% mixed. Now, I always like to point out the 4% mix because although that's a thin slice of this pie in a city of 8 million people, that's hundreds of thousands of people for whom even that very simple definition of diversity does not quite categorize them precisely. But of course, the picture is much more complex than that, and you all know this. Here we're now using genetics to look at diversity, and this is a common tool we use in genomic research called a principal component analysis. And here on this plot, each dot in gray is a New Yorker in the BioMe biobank at Sinai. And what I've done here is I've also plotted populations from 7 different continents around the world. And basically the plot is very simple. You don't need to know the math underlying it. The closer point is to any of those reference panels, the more ancestry, genetic ancestry the individual has from those regions of the world. So quickly you can see that New Yorkers reside along a line of genetic ancestry that touches almost any of the 7 different continental regions of the world, so that you can start to think about that patterned dendrograph of New York City is a much more fluid continuum of genetic diversity, and there is some math and network-based approaches that we can use to get us a much more nuanced picture of the fine-scale population structure in New York that teaches us a lot more, we think, meaningful biology and information about the health of New Yorkers. If we do this, we can start to pick up communities that represent meaningful communities such as Ashkenazi Jewish communities, Puerto Rican communities, Dominican communities, and we can think about this in terms of monitoring not just genomics, but also culture, environment, and behaviors that impact people's health outcomes. And so these are the types of programs that are very much underway at Sinai, really thinking about a much more nuanced, fluid representation of the health of New Yorkers, linked not only to our electronic health records, but the kinds of things we do these days, for example, with health devices, and thinking about the environment around us. In terms of lots of things, air quality, built environment, etc. And now we can start to build a much fuller, richer matrix of information to help us learn about health outcomes. And we can start to really explore, as Dr. Stewart mentioned, the continuum of disease from monogenic rare disease to complex disease and all the factors that impact outcomes. And of course, anything we learn in New York City is almost bound to tell us about many other places in the world. About 35% of New Yorkers were born outside of New York. If you go back a couple of generations, that goes up to 65% of New Yorkers who have, a couple of grandparents who were born outside of the US. And that's really telling us a broader picture about global populations and the processes of migration and diaspora and assimilation to new environments. So here's a story that exemplifies this exactly, and this is one of Noura and my favorite stories because it's the first time we worked together. And this is the story of a disease called Steele syndrome, and interestingly, it impacts Puerto Rican populations much like Hermansky-Pudlak disease. And this was a monogenic recessive disorder, so you need 2 copies to have the disease, that had been characterized in 1993 in some families from Puerto Rico. And kids born with this disorder have these very distinctive morphological features, including short stature, born with severe bilateral hip dislocation, and many other features like carpal coalition, scoliosis, all sorts of features combined that suggest a disorder of bones and joints. It was described in 1993. There was a follow-up study in 2011 of the same families looking at things like quality of life outcomes for cases. And then in 2014, in a study from Baylor, they sequenced some of these families and discovered the molecular alteration underlying this disorder, which is this G2R molecular called collagen 27A1. By looking for that variant in our BioMe biobank, which these days has upwards of 50,000 participants from our health system, a good proportion of whom have Puerto Rican ancestry or were born in Puerto Rico, we actually discovered that this is not a rare disease at all. In fact, it's rather common. If you look at the frequency of this variant that causes Steele syndrome around the world, you'll see that it's actually quite common in Puerto Rican populations. So about 2% of Puerto Ricans carry this variant. So about 1 in 2,000, 1 in 3,000 Puerto Ricans will have this disease. We actually also found, and this is the kind of exploration that you can do when you have enough data about enough genomes of diverse humans, that indeed this is not simply a recessive disorder. And now we have good evidence that even if you are carrying 1 copy of this disease, this is also predisposing to not a severe manifestation, but quite significant manifestation of other spine and joint degradation. So upwards of 2% of New Yorkers who are complaining of back pain or joint pain, this might actually be one of the underlying reasons for that. But we can go back into our health system and we can recapitulate the clinical observations from that study from 1993 in adults walking around our health system. So there are 5 adults in our biobank who have 2 copies of this gene. And if you just go back retrospectively and look incidentally into their health records carefully, and this is with clinical experts, you will see evidence of the very same features that were described. So 4 out of 5 adults have congenital hip dislocation. 5 out of 5 have extreme short stature. So for females, an average of 4'4", for males, an average of 4'11". 4 out of 5 show evidence of cervical spine anomalies. 4 out of 5 have had large joint replacements before age 50. Now, this is starting to become new observations because in the previous study they were following children. Now we're seeing adults and what happens later in life. We've seen that many of these adults, 3 out of 5, have come into our emergency department with needing emergency spine surgery. And other features of the disease, such as scoliosis, osteoporosis, and arthritis. And this work was published in a paper in eLife Journal in 2007, led by Gillian Belbin, a postdoc in my lab. So how can we move this finding forward into clinical care? So this is what we did here in Mount Sinai. First, we thought about the impact of this syndrome in the pediatric patient population. Because, as I mentioned earlier, these children are born with severe spine dislocation, and one of the earlier studies followed these children, and there's a clinical recommendation that you do not surgically intervene with these children because it leads to worse outcomes. So Noura and I immediately approached the pediatric endocrinology and orthopedic team and spoke to them about this disorder, and immediately, you know, as we were speaking with the team, they said, oh, I think we've seen babies like this. We also here at Mount Sinai at the time had a very thriving high throughput molecular genetic testing laboratory that's now being spun out to a company called Semaphore. So we could cross the other side of campus and we could talk to them and we could say, look, we have this finding now. We think there's this disorder in our patient population. We really ought to build a genetic test to screen for this. And they said, yes, we'll do that. And within 6 weeks, they had developed a test. So now the pediatric team can start to send their patients for testing through medical genetic testing services. And I think the last time I spoke to the division chief there, I think they'd seen now about 7 patients coming through just pediatric endocrinology and orthopedics. So this is the kind of way in which we can bridge these kinds of findings into clinical care by reaching out to the clinical teams who would like to know this information and make appropriate recommendations for how to think about managing these patient groups. And this was something that we discovered in 2013. We built the test in 2014, and subsequent to that, we've now worked with the University of Puerto Rico to develop a newborn screening for this variant in Puerto Rico. We'll be testing about 30,000 babies a year for this disorder. But what about all the adults, 5 of whom are in our BioMe biobank, who are walking around Mount Sinai Health System never having been diagnosed with Steele syndrome? And we don't just guess that, we think we know it because we went back and we looked, for instance, of Steele syndrome in health records. And although they may have been diagnosed elsewhere, it's quite unlikely. Remember, we first molecularly characterized this very, very recently. And really in the literature, we've only ever found, 2 papers. So this is a rather obscure disease with regard to clinical evidence in the literature. However, we know, because we've got a very large Puerto Rican and Puerto Rican ancestry patient population in New York City, that we're going to have hundreds, if not more, people who have this disease that are in our health system, and we would like to be able to catch them. And that was really, one of the, foundational experiences that Noura and I had that really prompted us to think about ways in which we can preemptively screen our patient population and catch disorders like this, so that we can divert patients into better healthcare management strategies. So we are in the process of launching a new center. It's the Center for Genomic Health. Noura is going to speak to you next about exactly how we are thinking about rolling this kind of program out, and indeed have already started. So she can give you some early insights into how this is happening. And really the core of this program is thinking carefully about our patient population in New York City, a key characteristic of which is diversity. We see types of diseases, disorders in our population that are maybe not unique to us, but certainly unusual compared to other health systems, and what it will help teach us about how to inform better healthcare management. Noura?
Great, thank you. So I'm taking over from this part on to get into some of the granular details about what is the Center for Genomic Health and why are we doing this? But I think Eimear has outlined the big picture and why this can be really impactful. And certainly our example and experience with Steele syndrome was mind-altering for us. So we're really excited to be presenting this and to be launching this center. So some of the elements that go into building this kind of entity already exist all around us. And Eimear has pointed out many of these things already. I don't know if I can point, but here. So we have really strong experience and expertise in genomic discovery that we really want to bring into clinical care whenever it's appropriate. We have a BioMe biobank at Mount Sinai where we're launching a lot of discoveries and have had many experiences with discovery, and I'll give you a little bit more detail about what that looks like. We're thinking about ways to incorporate more genomic education and training so that all of our physicians are really embracing this new era of genomic medicine or precision medicine. And we certainly have the expertise in precision health, and we have leadership that is very much invested in genomic health. So a lot of what we're doing is actually already in place, and we're trying to bring it together in this cohesive way for the Center for Genomic Health that will outreach to the whole Mount Sinai health system. So one of the first things that we have already started to do is to return genomic results to participants of our BioMe biobank. Eimear mentioned the BioMe biobank. I don't know how familiar all of you are with our biobank, so I'll briefly describe it. We are a biorepository that now, as Eimear mentioned, has about 50,000 participants that are patients across the Mount Sinai health system. The only requirement to participate in the BioMe biobank is to have interacted with the Mount Sinai health system and have a medical record number at some point. So we are actively accruing and recruiting patients and enrolling them into our biobank. Everybody who's enrolled signs a consent form allowing us to have access to de-identified electronic health records. They provide a sample from which we process DNA and plasma, and then we can do genomic studies on that sample and link it to clinical information from the healthcare record. And this is how Eimear's group had discovered the variant for Steele syndrome and its frequency. And there are many ongoing studies that are similar to that. We now have over 31,000 participants of BioMe who have whole exome sequence data that we have through a collaboration with Regeneron Pharmaceuticals and the Regeneron Genetics Center, where I actually spent the last 2.5 years before returning to Mount Sinai for this exciting new role. And since, I should have updated this. It's not last week anymore, but since October 5th, so about a month ago, we now have a return of results program that has been IRB approved and that we have already commenced to work on to return medically actionable genetic information to our BioMe participants. And that's what we're doing now, and that's a little bit about what I want to describe, what we envision genomic screening to look like and how we're using BioMe to learn about how to apply this more broadly across the health system. So what's a medically actionable genetic condition or genetic variant? There are some guidelines that exist because more and more we see exome and genome sequencing happening in clinical and research realms. And what happens is that you're querying something that gives you a lot of information, usually for diagnostic purposes, but there's always a chance that you're going to uncover something that's unrelated to the reason that the test was pursued in the first place. Much like getting a CAT scan for somebody who's had a bump on their head and then finding a mass that was unexpected. So these kinds of incidental findings became something of concern in the clinical world initially, and guidelines were set forth as to what incidental findings should be reported to individuals having undergone clinical exome or whole genome sequencing. This was then extended to individuals who've had this kind of sequencing for research purposes as well. So there are some guidelines as to what's considered medically actionable and that you should be returning to patients if they've had sequence data generated. And we're trying to kind of use this information and understand what would be considered actionable in our health system to screen for. The term medically actionable in this context means that there is some kind of intervention that can be undertaken to either prevent a disease from occurring or reduce the morbidity and mortality from said disease. So an earlier diagnosis, a personalized treatment based on the molecular etiology as evidenced by the sequencing. Conditions that are most often considered medically actionable today are those that are highly penetrant. So if you have a genetic variant in a disease gene, you are very likely to have that disease or end up having that disease in your lifetime. So those are just some terms that I think are important to define. So we look for this kind of medically actionable genetic condition in the BioMe biobank to see what we would want to return. And the way we present this to participants is that they now have the opportunity to learn about genetic conditions that are of high medical importance that would impact their clinical care. And what we found since we launched this Return of Results program is that the majority of people that are participating in BioMe are really interested in learning this kind of information about themselves. Almost 90% are consenting to have results returned to them that are medically actionable. So within that context, we then look at the genetic variants in those disease genes that are considered actionable and try to define this category of pathogenic or likely pathogenic. So variants that have over a 90% likelihood of being associated with the condition in question. And those are considered to be what's clinically acted upon. I want to give a couple of examples of what is medically actionable and things that we are looking at today in the BioMe Biobank for our Return of Results program. And these are 3 conditions that hopefully many of you are familiar with: hereditary breast and ovarian cancer, the BRCA1 and 2 genes, familial hypercholesterolemia, with LDLR, ApoB, PCSK9, and Lynch syndrome, another perhaps less familiar cancer risk syndrome that's more associated with colorectal cancer and endometrial cancers and others with these 4 genes associated. And the reason that we've really been focusing first and foremost on these 3 actionable conditions is that firstly, there is a lot of action that can be undertaken to reduce morbidity and mortality here. And very importantly, the CDC currently considers these 3 conditions as having enough evidence to really consider applying as a public health screening measure. Much like newborn screening is applied today in every state, there's starting to be enough evidence that perhaps we should be doing some kind of unselected screening for these conditions in our population. And I want to point out here that familial hypercholesterolemia is something that I had the pleasure of working with one of the residents from your program here, Reena Garg, over the summer. And she's here today after being on call last night. So thank you for coming. And these are some of our very early observations in BioMe that Reena and others have been working on to understand what is the prevalence of these actionable conditions in our patient population. And you can see that overall, the prevalence of now being a heterozygous carrier of a genetic variant associated with one of these conditions is close to 1 in 80. And what's really interesting is that there have been other studies, and Eimear talked about the Geisinger Health System, which was really one of the pioneers in establishing a Genomics-First program. And when you look at the prevalence of these conditions that they observed in a separate biobank in rural Pennsylvania that looks very different than our biobank in New York in terms of diversity, they actually saw something extremely similar in terms of prevalence, 1 in 78. So we really suspect that despite individual differences in prevalence of these genetic conditions or harboring genetic variants for these conditions, that probably 1 in 78, 1 in 80 individuals really are carrying a pathogenic or likely pathogenic variant that's associated with one of these conditions, which makes the prevalence pretty remarkable in my point of view. So I do want to point out a little bit more about one of these conditions, hereditary breast and ovarian cancer, where we found an estimated prevalence of 1 in 136 individuals. That's extremely high, and it was unexpectedly high for a condition that's pretty well characterized. So this is one of the more well-known genetic conditions that there is screening available for. There's been a lot of publicity around it. People know about the BRCA genes and the risk for breast and ovarian and other cancers and get tested for that if they have family history. So previous to this, the expected prevalence worldwide was thought to be around 1 in 400. And then in the Geisinger Health System, they had published a prevalence that actually ended up being closer to 1 in 190. But then we're seeing something that's even higher prevalence than that, 1 in 136. And these are the kind of things we want to explore further in our patient population. And that can be explained by our diversity. So this is the explanation for why we have such a high prevalence of BRCA1, BRCA2. This is showing individuals who have Ashkenazi Jewish genetic ancestry. So this is, again, work that Eimear's postdocs and other lab members are doing. And we can identify by genetics over 4,000 individuals with some Ashkenazi Jewish genetic ancestry. And it's well known that there are 3 founder mutations in this population that often people get screened for. And if you just take those 4,000 plus individuals in BioMe and look at the prevalence of being a carrier for a BRCA1 or 2 variant, that prevalence is 1 in 47, because we actually have 81 individuals carrying just one of these 3 variants. So our total of 1 in 47 almost exactly recapitulates what's known and what you'll see published in the literature about this population that's been relatively well studied for BRCA1, BRCA2. We start to see similar examples now in other founder populations that are perhaps not as well characterized in the literature because they've been, as Eimear mentioned, relatively underrepresented in the genomic space. So these are the kind of things that we're learning through this program and the kind of things that are going to help us advance genomic medicine and genomic health through the Mount Sinai Health System. So what does a return of results program look like? I mentioned that we have research exome sequencing for a subset of our BioMe biobank, about 31,000 individuals. So we're using this to kind of develop a return of results program and first looking for whether there's a suspected actionable genetic result in a sample. If there's not an actionable result, then we have that sequence data and we can always revisit it because what's actionable is what's based on our knowledge today, and that will continue to grow and change with time. So that's an important thing to note, that we will always have these data to look back on and be able to engage our patients and return important results to them as needed. So let's say we do suspect that there's an actionable genetic result. We have to clinically confirm that. We've partnered with Semaphore, a New York State approved and CLIA certified lab, to get a clinical confirmation because remember, these exome sequencers were generated by research methods, so we need a clinical test to confirm any variant that's suspected as actionable. And again, if that result does not get clinically confirmed by a lab, we do not return the result. If there's a clinical confirmation, a report gets generated that looks just like a clinical genetic test report, that you have this variant in BRCA1 that's been linked to hereditary breast and ovarian cancer, for example. And that will trigger a return of results visit through our Center for Genomic Health. We have a team of genetic counselors that we're building up who will carefully communicate these kinds of results to our BioMe biobank participants. And then those participants would undergo a condition-specific evaluation. And what we're really interested in learning is there any personal or family history that's related to signs and symptoms of that condition? We can obtain some of these data through de-identified electronic health records, but there's a lot that you gain by doing very careful family histories, as you know. And then we're tying in those results with very specific recommendations as to what to do with that. This program does not end with us giving a report back to patients. It ends with us giving very specific referrals and recommendations for how to follow up on that result. And this entails a lot of engaging with our clinicians through the Mount Sinai Health System for them to understand what to do with the genomic results coming as the first symptom, for example. So this Genomics-First Approach can be complicated. I'm not going to go through this in very great detail, but I think it's important to conceptualize what is this new era of genomic medicine going to look like when we have patients more and more coming to physicians with a genetic report, either from direct-to-consumer testing or through clinical genetic tests such as we're generating through the BioMe biobank experience. So someone comes with a genomic result, there's many different outcomes from that. There are going to be individuals who have had previous clinical genetic testing for the condition that we have identified a result for. So in that case, they already know that they have, for example, BRCA1 because of a strong family history or a personal history of a cancer. And then that diagnosis has already been made. So that's probably the simplest scenario. We're not necessarily giving new information, but following up on a previous finding that was done in a clinical setting. We actually have found that the majority of people do not necessarily know that they have a condition, have a variant associated with a condition through our early findings. So then some individuals maybe have had a clinical diagnosis made, but not the genetic test to confirm that from a molecular standpoint. In that case, that's quite simple. Also, they know they have a family history of cancer, or they have themselves, for example, breast cancer, and now you've given them a molecular reason for that. So that's the second bucket. And then there are going to be individuals who don't know that they have they're at risk for some condition, and we give them this genotype or the variant that's suggesting that they're high risk for a condition. And when we evaluate them, we find out through taking a detailed family history that there is a recurrent risk of early ovarian cancer and breast cancer in their family. And then the diagnosis is made again through that evaluation. So I think those are fairly straightforward scenarios and really what we hope for the most part, but we are going to find individuals that we find have a genetic risk for a condition, but when we evaluate them and when they go through their further evaluations with specialists that we have recommended, they don't have the phenotype initially, but then those individuals will get followed over time, and that's what we're in the process of discussing. There's not always guidelines as to what to do with a genomics first finding, so we need to establish that process. So if they get evaluated over time with more rigorous screening, for example, for cancer, perhaps we will be able to make an earlier diagnosis, and that's this fourth bucket where the phenotype emerges over time. And in some cases, they will go through that rigorous screening or more frequent screening, and the phenotype does not emerge over time. And we do expect that that will happen because these are highly penetrant conditions, but they're not 100% penetrant, which means that if someone is a carrier for a known established disease variant, they're not 100% going to get that disease in their lifetime. They're at higher risk than the general population, significantly higher risk, but it's not 100%. So that's going to be probably the more difficult situation, but we still think overall we do a lot of good by hopefully making very early diagnoses where we can. I should mention that this slide is something that's adapted from Michael Murray, who established the Genomics-First program at the Geisinger Health System and who now is part of our advisory board for the Center for Genomic Health. And this is a really important point. We're starting with now a genomic finding, a genomic result. That is not a diagnosis. It needs to be tied in with a clinical evaluation. And that's one thing that we always want to make clear, that we are not making a diagnosis, providing additional information that grows in the context of a full clinical evaluation. So all of this is being done to build up an infrastructure for genomic medicine across the Mount Sinai Health System. We're learning a lot of things from this process, including how to generate clinical results from research data through partnership with a clinical genetic testing lab. We are gaining genetic counseling expertise in genomic screening. This is not a traditional form of genetic counseling. We have many well-trained, excellent genetic counselors at Mount Sinai, but no one has been specifically trained really to do this kind of genomic screening. So we're figuring that out as we go along. And I mentioned this already. Our clinicians are now working with us to establish guidelines around genomics first findings. In some cases, it's pretty clear what the next steps are for someone who has a genetic variant putting them at risk for a condition, but sometimes there aren't, and we'll be the ones who help establish those guidelines. So we need that really context-specific evaluation. We need long-term follow-up strategies and management. This is another thing that becomes really important. Every time we identify someone at genetic risk for a condition, it's not just affecting that person, it's affecting their family members and their society around them. We need to figure out a way for individuals at risk to come in for clinical genetic testing, such that if a family member has been identified with a disease gene variant, we can then do targeted testing of their at-risk relatives for that variant and see whether they're carrying it or not. That's something called cascade screening. And finally, the clinical utility of establishing a broad genomic screening program has not been well established, mainly because this is very new technology, this is very new concept. We're getting more and more data about the clinical utility, but we'll be able to contribute a lot to this knowledge. In terms of patient outcomes, how do they feel about receiving their genetic results? What do they do with our recommendations? Do they follow them? Do they decide not to? Do they go on with their lives as usual? Do they tell their family members about the variant that's been identified in them, that's actually on the patient, to do that and share that information so that their at-risk relatives can also get tested? Those are the things we'll find out. What is the impact on the family and the society? And what are the costs for the patient, for the health system? And all of this is to scale our best practices as we launch the center to figure out how we apply genomic screening as part of preventive health for Mount Sinai patients. So I wanted to just give you some examples of what we have found in previous studies. And this is actually work done while I was at Regeneron through the Geisinger collaboration. And I mentioned some of it, but I think it's really important to understand the impact of a genomic screening genomic screening program. So some numbers that I thought were very impactful was that when we've previously done this with hereditary breast and ovarian cancer and BRCA1 and 2, we found that 82% of participants had not had prior clinical genetic testing. So the large majority did not know that they were harboring this risk. What's even more concerning is that about 50% would not have met current guidelines to obtain genetic counseling and genetic testing that's covered by insurance. So current practices today are missing about half of individuals who are at genetic risk for hereditary breast and ovarian cancer. This is an example of an individual who underwent the Return of Results program through the Geisinger health system and was found to have a BRCA1 variant and underwent the recommendations and follow-up that were given to her, and actually, and again, was someone whose family history would not have met criteria for traditional clinical genetic counseling and testing. And she came public with her story, and I think this is a really nice example of the impact that a program like this can have. So this is Barbara Barnes, who was 57 years old at the time and was the primary caregiver for 3 grandchildren. And she was found to have a BRCA1 pathogenic variant and wanted to know what to do and wanted to make sure she was around to raise her grandkids. So she actually underwent risk-reducing surgery of the ovarian and fallopian tubes and was found to have a very early stage fallopian tube cancer, stage 1C, which, as I'm sure many of you know, is kind of uncommon to find at that stage. Typically, they're aggressive tumors that are only found later on. So she has had an early diagnosis. She's undergone chemotherapy and completed that and is expected to have an excellent outcome because of this program. And we hope to see a lot of success stories like this through genomic screening that we've launched now at Mount Sinai. So some of the things that we're going to find, Eimear mentioned Steele syndrome, and one of the things that we really were surprised by was the prevalence. So we're probably going to find this more and more. If you unselectedly screen individuals for genomic conditions, you're likely to find that those conditions are more prevalent than previously expected, certainly going to be more common in some populations than rare. We also found that Steele syndrome was underdiagnosed in adults in our health system because a lot of these genetic conditions do go undiagnosed. For Steele syndrome, short stature, some mild dysmorphic features, and scoliosis of the spine and hip dysplasia does not necessarily trigger a Steele syndrome diagnosis, right? We found similar things in the Geisinger health system with something I mentioned earlier, familial hypercholesterolemia. Again, same theme. This was a highly prevalent disorder compared to what was previously known, and very few of individuals that we found to be variant positive for FH were diagnosed with that condition clinically. And what was even more interesting was that it was very undertreated, and this is high cholesterol that we know how to treat with lipid-lowering therapy, but among individuals who were variant positive, less than 50% had achieved an LDL level under 100, which perhaps is overly aggressive, but still an indicator that we could do better. If we knew the molecular diagnosis for individuals with familial hypercholesterolemia, we would surveil them more frequently, and we would make sure to be lowering their lipids as much as possible to prevent early CAD. So are we ready for this next era of genomic medicine, and what are we doing to prepare our medical students and our residents and our attendings for this? I had a medical student work with me to understand whether medical students at the Icahn School of Medicine were prepared for personalized medicine, and throughout the years, really 6% felt that their medical education was preparing them adequately to practice personalized medicine, which is another way to say genomic medicine and precision medicine. And only 36% felt that they knew enough about genomics to interpret direct-to-consumer tests, something that Eimear mentioned. 20 million people in America have some kind of direct-to-consumer genetic testing. We actually did this also in residents and physicians in internal medicine. This was mostly residents, and we called it personalized genetic testing, or same thing as direct-to-consumer testing, and found that most individuals did not feel comfortable enough to say they definitely knew how to interpret those kinds of test results. So I'll show you an example of what we expect to be seeing more and more coming through the clinic. Even if we don't have our own genomic screening program, people can obtain this information elsewhere. This is mine from 23andMe telling me that I have I do not have a variant in BRCA1 or BRCA2, which can be very reassuring for people to see that kind of information. However, if you read the fine print, you see that they've only tested for 3 genetic variants, and those are the 3 founder mutations that are common in Ashkenazi Jewish individuals. I'm not of Ashkenazi Jewish descent, so this is not meaningful information for me. We need physicians to be able to understand the intricacies of genomic results and interpret them. Otherwise, this can provide false reassurance for someone who perhaps has a very strong family history indicating a high genetic risk for a condition like hereditary breast and ovarian cancer. So we've entered a world where the medicine is a bit of a changing paradigm, and these are all of these different things going into how we think about precision medicine, the big omics, big data, mobile health, artificial intelligence, direct-to-consumer testing, and there are not enough medical geneticists to take on all of this. There are very few actually per million population. There are now over 4,000 genetic counselors in the US and Canada, and that is a workforce that's growing probably by 30% over the next 10 years. But I'll leave you with this. There are over 74,000 now genetic tests that are commercially available in the US, and there are 14 new tests that enter the market every day. So I think we need to understand that genomics has to become accessible to physicians across all specialties, and the Center for Genomic Health has as a mission to really make that possible across the Mount Sinai health system. So hopefully you'll start to see how this unfolds over the next year or two and affects patient care here and elsewhere in the health system. I'm going to end there with many acknowledgements. We have here the current members of the Center for Genomic Health, which is small but growing at Mount Sinai, the Institute for Personalized Medicine, where the Mount Sinai BioMe Biobank is hosted, and its director is Judy Cho. Departments of Medicine and Genetics and Genomic Sciences are very much involved and stakeholders in this program. And I think most importantly, the thousands of biobank researchers that we have here and elsewhere who are making all of this work possible. And thank you all for the opportunity to come here and speak to you.
Questions?
This is a very exciting program, and I'm really looking forward to learning a lot more about it. I guess I need to understand this a little bit better, especially since there is so much diversity and increasing intermarriages, which may actually dilute the gene pool for expressing these diseases. Or are we talking only about very dominant genes, so that you only need one gene for the phenotype to be expressed, or at least in some form of disease at an unknown time? So what of the other genes, for example, sickle cell and other rare disorders, in which we can determine when it's appropriate to do the testing, separate from the ones you've already shown us about, that we know more about? And what is the cost of doing this testing, and is the insurance covering it, and when it's going to be on Epic?
Right, so maybe I'll answer some of that. So most of the conditions that we will screen for are exactly as you said, going to be autosomal dominant conditions, except for cases where autosomal recessive conditions are known to be relatively common in certain populations. And as we start to see more and more, those recessive conditions can actually manifest in heterozygous carriers of those gene variants. So this is a program that we're giving you a tiny slice of, this is how we've launched, but we'll grow in the number of conditions that are screened for, based on what's known as being actionable, what there are guidelines around, and what our health system wants to hear about. We want to make sure our clinicians are ready to follow individuals that have been screened for certain conditions, so we'll be very careful in how we roll that out. As for I think with cost and insurance coverage, so for the Return of Results program, we actually are funding that internally to return results to our BioMe Biobank participants. that is at no cost to them, and we provide that genetic counseling free of charge as well. Subsequent to that, they have a clinical report, and anything that comes after that genetic counseling return of results visit becomes standard clinical care, so it's either covered by insurance or out-of-pocket cost. Was there some? Oh, and EPIC. Sorry, and the last thing I think was whether when there's a clinical genetic test report, that does become part of the clinical care in EPIC as a standard.
Hi, good morning. I have a question. Are you guys testing also for genes that are protective to diseases? We have a large HIV population and some are any controllers, so we suspect that they could be carriers of the CCR5 mutant, but is there a way that your program can help us test these populations?
Certainly. So, you know, that's if there's actionability around a variant, whether it's protective or risk variant, I think that's important knowledge. As long as we know how that data is going to be used in a clinical setting, we're interested in learning more and figuring out whether that's something we should be testing for. So that's the kind of information we want to hear. If you say, if we know about CCR5 in our HIV patients, we will stratify them differently or treat them differently based on that information, that's something that we should consider testing for.
Yeah, and also remember, this is an active research program as well. So even if this is not something that might change clinical care today, but you were still interested to develop evidence around how we should be thinking about it, we're actively building that kind of research into how we're building this program.
I thought it was a wonderful talk. I apologize for coming in late. I have probably a radical suggestion to add to this program, and that is the clinical history. And I think it's, I suspect that this is where the whole genomic program starts, basically from the family history, one way or the other. And I suspect if we go up to the floors now and look at any medical service history, there is no significant mention of the family history. The other thing that I think is important is to ask people and yourself what the ethnicity and the term race is. I also understand recently that the term African American or white or whatever has been barred from its use in the medical history throughout the Mount Sinai system, which I think is a tremendous potential detriment of patients. Because if you close your eyes to something as obvious as an Asian origin or an African origin or some other origin, you're potentially losing a lot of information. I mean, you know better than most of us the difference in genetic responses for a whole host of conditions in different genetic groups.
Yeah. So the family history, definitely agree with you, and that's why we think that context-specific evaluation that's focused on personal and family history is going to be essential to this program. And I suspect, as you said, we'll uncover a lot of things that are hidden in that when we apply it.
Correct. But do you think that a detailed family history, parents, grandparents, cousins, nieces, nephews should be included in the medical history?
I mean, as a medical geneticist in training, yes. But understanding, I also did internal medicine residency and understand that with the time constraints, it's difficult. We obtain very complex pedigrees in genetics. And
I understand that, but the fact is, if you think about the return on investment of a question, a set of questions that takes about, in my experience, 30 seconds or 25 seconds versus sending in a test that may cost $100 or $1,000, I think the calculus suggests that the question is cheaper than the test.
Yeah, you're right. You're absolutely right. And there are actually ways that other people are thinking about incorporating family history tools into the EHR that will make that easily and more structured data in electronic health records. So hopefully we'll see more of that and see that come to Mount Sinai too.
Yeah, and just to pick up on the earlier question, so we know that there are some diseases where we see the prevalence of disease fairly evenly almost anywhere in the world that you look. But there's many examples of genetic diseases and disorders, whether it's caused by one variant or a collection aggregate of variant and environment, that you do see that are local to some population groups, and how well or not they correlate with any type of population group label like race, ethnicity, country of origin is a separate question, but I do think that that's important information that should be used together to try and actually treat patients and identify populations at risk.
How many dollars would you spend screening Garrison Keillor's Norwegian Lutheran farmers for sickle cell disease?
Not very many, but I'll flip that on you, because there was a recent case of a young man of Spanish origin who was found to have sickle cell. He presented with sickle cell symptoms, and it's because he has an African haplotype. He looks like a European child, but he actually has an African haplotype at the locus. And so we ought to expect this. We ought to, this is the advantage of a genome-first approach, that we can actually empirically uncover these rather than in a better way, a more nuanced way to identify populations and individuals at risk.
How's confidentiality being handled? I have patients who maybe their family members, their younger family members, don't want genes to be known because then they don't qualify for life insurance.
Yeah, that's a really important question, and so there are some measures in place. There is a federal law against health insurance discriminating using genetic information that's called GINA, G-I-N-A. It doesn't prohibit some other forms of insurance like life and disability from discriminating against genetic information. So that is important, and we make sure that that's well addressed in our consent process and that our patients are aware of that. The confidentiality is akin to anything else in medical care. So patients have their clinical information, and that's in the medical record, and so the privacy is akin to everything else. In terms of childhood or adult onset conditions in children, we're not offering results for adult onset conditions to children. So anyone under the age of 18 is not eligible to receive those results because they themselves would not have consented for that. And that's typical in clinical genetics practice. If they reconsent at age 18 for the BioMe Biobank, they can then consent to receive results for adult onset conditions. That being said, there are pediatric onset conditions that are considered actionable and returnable, like Wilson's disease, for example. So we would return those to parents of pediatric children in the biobank.
But the records are kept in the main medical records. They're not kept separately. So that insurance companies can find them.
So anything that becomes a clinical report becomes part of the record. Anything that's generated for research is not kept in the medical record. So there's no knowledge that they are in the BioMe Biobank through their EPIC chart, for example. That's kept completely separate. But if they sign up to receive genetic results as part of a clinical program through the Center for Genomic Health, that does become clinical care.
We have a question downtown. Good morning. Heather, can you hear me okay?
Yes.
Yes. I just had a question. So, all these population overview talks or disease-specific are incredibly optimistic and uplifting. But built into this is an incredible business model as well. You have cascade screening, you have increased imaging, people are put into a certain healthcare system. What are kind of the ethical issues, or how do we handle the direction where some of this will be going, where each hospital system or organization sort of has their own biobank, wants to retain their own patient population? Kind of where is this heading from sort of not abusing this population to create your own captive audience?
Did I mention you get hard questions?
Yeah. Were we right to present here? No, that's a great question. Certainly, we want to tie in what we return as genetic results that becomes clinical care with recommendations for follow-up. There is no obligation that that follow-up be within the Mount Sinai Health System. Of course, we can, recommend clinicians that we have outreach to and that we're discussing this program with, and who have agreed to see patients from this perspective, which is really a novel way to start seeing patients. So there's a lot of internal investment into producing a program like this. We don't know what that return will look like, and it will be across the health system, across New York and other health systems. So, there's a lot of modeling that will take place to understand the economics around this. But certainly, we understanding that BioMe Biobank is something that Mount Sinai is very proud of. We also understand that our patients receive their care in many different places. We just really want to return results that may impact that care wherever they go.
I just want to follow up and make a comment from my own experience, and that is that, and I think everyone would agree with me on this, caring for patients is a lot about helping to manage their anxiety. And patients present to us almost to a person with anxiety. And part of that anxiety is around things they know. They know about themselves, they know about their families, they know about their personal, ethnic, or genetic background, and other things that are much more inchoate. And so my own view, 20 years in, is that patients really do want to know. And in moments where we're saying we're not doing this test for X and Y reason, they frequently leave that encounter with us with a fairly high degree of skepticism. That what we're saying is the reason not to do something really completely makes sense. Just following up on Oscar and sticking with my own population, the HPS population, we know the carrier frequency for HPS1 is about 1 in 16 in northwest Puerto Rico. We also know that we've identified patients with HPS on every continent in the world other than Antarctica. So that there's just a tension that exists, and I think we just have to be very careful about being too rigid in how we think about disease risk.
Yes, I wanted to express that the most common thing that is seen that relates to your talk today is people with women with a BRCA1, BRCA2 breast mass that's been excised, and you get this report back. About 10 years ago, I went to a conference, and I only went to the conference because it was at a ski resort. It was
a good reason.
Johns Hopkins, and it was a gastrointestinal conference. And one of the things they talked about was the relationship of BRCA1, BRCA2 to pancreatic cancer. Well, I came back from the conference, and I said, well, this is interesting information. And the next week, I had this lady who had a breast biopsy, and she came to me, and I had the results, and it said that it was a BRCA1 genetic variant. So, I was interested to see if she had any relatives that had cancer. She didn't know of what happened to her relatives in Europe, but she did have 2 brothers. So I told her about this finding, which was brand new at the time. And she said, I asked her if I could contact her brothers. So one of the brothers lived in Baltimore, and both brothers were legal. They were lawyers. And I called up the brother, and at first he was quite offensed. It was like kind of an umbrage that I would call him up and tell him he might be at risk. Anyway, I did get through to him and give him the name of the doctor who had given the lecture at Vail, Colorado, and he went to see the doctor, and he also had to fight to get a CAT scan, but they found that he did have a small tumor of his pancreas. So they removed the tumor, and I get a card from him every Christmas saying, "Thank you for following up. I'm sorry I was a little annoyed," but it brings up, the Steele syndrome I'm interested in. I think I've probably seen people like this because there's so many poor BRCA1 gene and the pancreatic and ovarian cancer that are really important to follow up on the relatives. And the children.
Yes.
Sometimes the person is has a child, and you say, well, what are you going to do about counseling your 16-year-old daughter about this? These are really hard questions. I think you've helped me with a little confidence building, but still, these are hard questions.
Yeah, we certainly don't take it lightly. Agree that these are complicated issues that we're dealing with, and congratulations on probably saving someone's life with the pancreatic cancer diagnosis made very early. It's extremely rare to do that, and now we know there's a well-established increased risk for pancreatic cancer and BRCA carriers, and are figuring out exactly how to have them seen by somebody in our health system who really specializes in pancreatic cancer risk. So, we're thinking about that and thinking about a lot of different scenarios. There's increased risk for many different things with BRCA1 and 2, including melanoma and prostate cancer, male breast cancer, etc. So we want to make sure that we comprehensively assess our participants who are found to be positive and make sure they get followed up.
Well, the last question I have is, what is your contact information? How do we reach you?
I'm glad you asked. It is now on the screen. Please feel free to email us if you have any further questions or feedback.
No, I do want to get in touch with you specifically about a family with a rare, so-called rare disease. So that's why I need to know how to contact you. So where is the?
Oh, are you able to see it on the screen or?
No.
Oh, not anymore. I'm
I'll
sorry.
email you, Norm. I'll email you.
Oh, okay, great.
Okay.
Thanks.
Okay. Thank you very much.
Thank you.